Thank you very much for the kind introduction. Good morning. It is my pleasure and truly my great honor to speak to all of you here today. And in this talk, I'm going to introduce you to some exciting programs which have been implemented with prevention equity at its heart. And I will proceed to end by a discussion of how you can implement one of these exciting models in your very own settings. And each country, each region has its own epidemic. The proportions of key populations in each country, each region are also different. However, key populations share one same thing, an extremely high risk of acquiring HIV. And the risk is 49 times higher in transgender women compared to general populations, 24 times higher in men who have sex with men and people who inject drugs, 10-fold higher in sex workers and 5-fold higher in prisoners. So how do we achieve prevention equity? And we all know that populations at highest risk for HIV are being left behind in so many settings. In women, we have heard a lot from yesterday's plenary session. They are facing harmful gender norms and inequalities. They are facing insufficient access to education and health services. In men who have sex with men, transgender women, people who inject drugs, sex workers, they are all being marginalized due to stigma and criminalization towards same-sex relationship, drug use, and also sex works, which limit their access to HIV services and also create reluctance among providers in order to reach out to them. Therefore, innovative packages of HIV testing and prevention tools need to be designed and delivered with meaningful, with true, with sincere involvement of each population for their own populations. Let's start with a key movement in Thailand first. In my country, more than 50% of new HIV cases occur in men who have sex with men and transgender women. However, HIV testing coverage among these key populations are still less than 30%. Therefore, the key population-led test and start program has been initiated with support from USAID PEPFAR for drop-in centers in 4 key provinces who are working with men who have sex with men and transgender women. The key population-led test and start program has proved feasible and very effective in reaching and bridging high-risk MSM and TG into the program, as you can see here with a high prevalence of HIV at 16%. The program can also reach MSM and TG who had lower levels of education and income as compared to those who accessed a conventional HIV testing clinic. The program can also diagnose those with HIV at an earlier stage with a median CD4 count of only 375, which is much higher than a median CD4 count of just above 100 at the national level. The key population program can also successfully link those who tested positive into care, with 83% successfully started ART within a median time of only 15 days after HIV diagnosis. And at 6 months after ART, 82% already achieved viral load suppression. The key population-led program has successfully engaged Thai MOPH throughout the process. And in this program, members of MSM and TG communities have their capacity strengthened to be able to perform finger prick blood collection and use blood collected to do HIV testing, syphilis testing, and CD4 measurement through the use of the rapid test kits and also the point of care machines. They can also collect samples from the anus, from the neovagina, from the oropharynx for STI screening. They can also do TB screening and prevention. And the latest addition is to have their capacity built to provide PrEP to their own friends in their own community health centers. And the ongoing training and coaching and QA/QI activities are being conducted by the local public health facilities. And the provincial health office in each of these key provinces are now considering these community health centers run by people from the community as one of the province's official HIV service delivering units. more and more members of MSM, male sex workers, transgender sex workers population are getting empowered to provide services, high quality services to their friends and becoming a community health workers, a proud community health workers. Sui, whose picture is shown here on your left, is one of our community health worker champions. She is sitting among us here today. Sui, could you please stand up? Sui. Sui has come a long way from being a sex worker to now also being a proud community health worker champion in our country. She can provide high quality HIV testing, high quality PrEP service to her friends in her own community health centers. And these lay providers truly earn their rights to wear the white coats. And our country is moved towards having the key population-led program. Among 300 MSM and TG HIV tested HIV negative who we started to offer PrEP since October last year. 54% accepted to be on PrEP, and now we are expanding this community-led PrEP program to a larger number of key populations through the availability of the Princess Somsawali HIV Prevention Fund, along with funding support from linkages. This Princess Somsawali Prevention Fund is a public donation fund to the Thai Red Cross, and our princess has been kind enough to provide her blessing quote to give courage and also to give her royal family support for the key population-led PrEP program. And just over 3-month period, we have already had almost 300 MSM and TG who access PrEP through this program. And the aim is to expand this program to 1,000 MSM and TG per year for the next 3 years, while we are waiting for our country to integrate PrEP as part of the national healthcare schemes. And now, with the growing interest and growing need to have transgender-specific data, the country has just established the Tangerine Community Health Center last year. And this is the Translate Integrated Hormone Therapy and Sexual Health Service for trans women and trans men. And among those trans women who access the service in our clinic, 9% were tested HIV positive. 16% have had sexual reassignment surgery. None of them ever had neovaginal exam after the surgery prior to coming to our clinic. And a look at the subset of these trans women identified that 80% of them had neovaginal sex and 20% of them carried high risk or oncogenic HPV types in their neovagina. So this may pose them at higher risk of developing neovaginal cancer in the future. All these information together are so crucial for us to plan ahead how we can have a long-term care model for these women in the region and also in the country. And recently, the Tangerine team has also reached out to a few transgender community-based organization in order to build their capacity, the capacity of TG-led providers to provide hormone monitoring services. And this is very important as concerns around drug interaction between hormone therapy and ART, hormone therapy and PrEP are so important for adherence to PrEP or adherence to ART among these populations. And now let's touch on the online technology. Thailand has more than 100% mobile phone user penetration, and 1/3 of them are using smartphone. This eCascade, currently piloted by Linkages Thailand, allows us to track real-time the referral across the HIV cascade from outreach workers to HIV testing clinic and then to ART clinic so that we can respond efficiently to client dropout. The eCascade system can also allow us to identify high-value social networks for recruitment so that we know where we should target our efforts, our resources in order to improve the value for money. again, still around the online technology. We all know that young MSM and TG, they are connecting online to engage in offline risk. And we know that it's not too challenging to reach these MSM and TG online. And the AdamServe website is one of the most active and successful online platforms that have reached millions of MSM and TG over a 4-year period. And it is also successful to engage these people to discuss their sexual health concern online. However, the real challenge is how you can convert this successful online reach into successful offline uptake of the services. And during the first quarter of this year, the AdamServe team has demonstrated the feasibility of its online to offline campaign. And in this campaign, high-risk MSM and TG are reached online and are offered education around HIV testing and PrEP. And if they are interested in getting the service, then they can proceed to do online booking. And you will then get this ticket with a QR code that you can present to the clinic to get the fast-track services. And just over a 3-month period, 425 people did the online booking, and 76% here actually presented to the clinic, and half of them started PrEP. Online technology can also be used to enhance the HIV testing step by providing a private and secure platform for self-testing. With support from AMFAR, we are exploring the online supervised HIV self-testing model for MSM and transgender women. And this is possible with every step happening online, with the online platform that allows the real-time video chatting features so that the client and the counselor can meet online and go through the self-testing process together in their own privacy, but with real-time supervision provided by trained counselors. And you can see here, it's Sui again, who is providing this online supervised HIV self-testing to her clients in the clinic. And compared to conventional HIV testing, we have seen that the online supervised HIV self-testing can reach more of those who were first-time testers and who had a very high prevalence of HIV, especially if this is conducted by a trained community health workers. Now let's step outside of Thailand and look at the other innovations in other places. San Francisco is one of the places where 86% of new HIV infections are happening among gay and bisexual men. And San Francisco has this willingness to go first over the past 3 decades. This is the willingness to rapidly adopt tactics that worked in pilot programs, worked in clinical trials, prior to the official endorsement of the public health authorities. And by its rapid adoption of the test and treat strategy, much earlier than the other cities in 2010, along with the citywide linkage to care program and a citywide PrEP program started in 2012, all these together has led San Francisco to start to see the decline in the number of new HIV cases. And these are happening because of that the key stakeholders, including civil society, state government, researchers, providers, they're not afraid to work together. And it's not just only work together collaboratively, they work together concertedly in order to get to that collective impact for getting to zero. In Vancouver, Insite is a very successful supervised injection site which provides a safe environment for drug users to inject their own drugs under the supervision of a nurse. And over a 15 years period, we have seen a dramatic decline in the number of deaths related to drug overdose by 35%. And Insite has proved to be an entry point for people who use drugs to access the drug addiction treatment. And this is a program which receives full support from the Supreme Court of Canada and also from other leading national health organizations in the country. In Uganda and Kenya, search program has implemented the community-centered approach to achieve the 90-90-90 targets. And in this model, community is actively engaged to create a sense of ownership to establish a chronic care system in their own community. HIV testing is provided through annual community health campaigns, household multi-disease testing, and testing of key populations. But all of this is done by nicely integrating the other health, education, and economic concerns of the communities into the same campaign. This is to reach the first 90. And in addition, the same-day ART and streamlined care with less frequent clinic visits, with shorter waiting time, with counseling based on viral load are incorporated in order to reach the other 290 targets. So, are we there yet? Getting to see the reduction in HIV incidence. In programs which have been implemented for many years, we have started to see the decline in the number of new HIV cases. In San Francisco, where concerted effort at a citywide level have been conducted, number of new HIV cases and also deaths have been declining over the past decade. In British Columbia, with Vancouver Supervised injection site, is the province in Canada where we've seen the largest reduction in the number of new HIV cases, particularly among people who inject drugs. In Eastern and Southern Africa, we have started to see a 4% decline in the number of new HIV infections over the past 5 years. However, there are certain settings where things seem to go very well, where key populations are included, but HIV incidence has not been decreasing, like in the UK, like in Australia. So, what should we do? Should we just look at the data and say 90, 90, 90, ending AIDS, having HIV incidence reduction? That's impossible. I told you so. Should we just do that? No. I think people with right minds will look at the data carefully and try to identify things that they can do better. Let's look at New South Wales as one of the examples. New South Wales has new HIV cases, 80% of them happening in MSM. And over the past 15 years, the number of new HIV has been stable but stubborn. Although around 90% of PLHIV already know their HIV status, and 90% of those diagnosed with HIV already are taking ART, with more than 90% of them achieving viral load suppression. So what is wrong here? The number of people who practice condom-less sex are gradually increasing. And could it be that this increased condom-less sex, together with that very small pocket of PLHIV who have not yet known their HIV status, can together continue to fuel the epidemic? If so, then can PrEP or even routine screening for acute HIV cases be key strategies to close down this gap? The City of New South Wales must be congratulated on their rapid actions and on their braveness to support the launch of the EPIC New South Wales program in order to rapidly increase access of PrEP to 3,700 high-risk people. And this again could not happen without the concerted effort between researchers, civil society, government, and also providers. And we hope to learn more from New South Wales in the next few years. So in conclusion, equity is needed for all key populations, and prevention equity is not out of reach. Prevention equity can be achieved, but you may need to have the following factors in combination in order to achieve one. Courage. You need to have courage. Because on the other hand, critics are easy to make. Critics, therefore, are more common. Many people think that this is a way that they are contributing to the world, making critics. Critics are not always bad. So listen, but be persistent. Whenever you hear critics, you have to work harder to provide more proof. Monitoring is also needed. Epidemics do change, and it is always better to take earlier actions. Innovations is also needed. Continue to find new collaborators with new sets of skills, and innovative and exciting models will always arise when commitment and enthusiasm are shared among stakeholders. Guidelines. We all love guidelines. But guidelines are there to guide you, not to force you to follow. You know your own epidemic. You know your own epidemic much better than the people who wrote the guidelines. So why don't you just design one program of your own and always aim higher than what the guidelines tell you to do? Policies, regulations, rules, they are all important, but they can be changed. With new evidence for the best of the people, these can be changed. And lastly, I think it is very important to find a champion in your country. Or why don't you just be one yourself? Thank you very much.